Recording. All right, so here we are, week two. So week two lecture is chapter six, which is ethics, and chapter seven, which is nursing and the law. So you have the PowerPoints are in the announcements for you. Um, so we will just kind of jump in then. I will share my screen. Do, do, do. Oops. I don't know what I just did, but that works. All right. It is crazy storming here. So in the event, this is what I meant to do. In the event that I get kicked off, it's been okay, but I was just watching I was watching the news. Don't ever watch, I don't know why I watch the news, but anyway, there was a tornado actually not too far from here. So although I don't know, sorry, I don't know what ton the tornado was. But it's just been really crazy the weather. So I do have my Zoom pulled up on my phone. So if power goes out, just bear with me while I just transition from one device to the other. The only issue that would have, using Zoom on my phone is that I can't share the PowerPoints. But like I said, if power goes out, that's the biggest issue I have. So again, we're going to do chapter six and chapter seven. So we'll start with ethics. And ethics is a system of standards or moral principles that direct actions as being right or wrong, right? It's how people, either individually or as a group, decide what actions are right or wrong. If one has the right to do something, if one has the duty to do something, or the right, or I'm sorry, what actions are right or wrong if you ought to do something, if you have the right to do something, or if one has the duty to do something. Very simple, very basic definition of what ethics is. So we look at professional versus personal ethics. And this is something as future nurses that you really need to take into consideration, okay? Personal ethics provide your personal guidelines for living, right? You get to choose what your personal code of ethics is, right? What you believe in, what you don't believe in, what you feel is right, what you feel is wrong, right? That is your personal code of ethics. Your personal code of ethics will influence your nursing ethics. And there are potentially times where your personal ethics are going to conflict with the law. And the law in nursing is our State Nurse Practice Act. Okay, so that that State Nurse Practice Act is what tells us, right, what we can do, what we can't do. Um, and it just provides those guidelines for how we, what we can do in nursing. So when we look at how personal ethics and professional ethics may clash. This is where it's really important to understand and know yourself, okay, what you believe in and what you don't believe in. And I know a lot of times, a lot of people use like controversial um, topics like abortion and things like that. This is a lot of times where that personal and that professional ethics may clash. All right. We have an obligation to follow the law, plain and simple. Okay. Wherever you're working, whether it's in an emergency room in a hospital, in a long-term care setting, in a clinic, right? We don't have control over the clients that we see or the patients that we see, right? So anybody that comes in to seek healthcare has a right to health care, right? They get the right to get treated this with respect and everything else. Um, but like I said, it's important to understand. So, like I said, I'm not going to go with the controversial abortion, but I'm going to use this one. So, you're working in the emergency room and you get notified that they are going to bring in a somebody that just got shot by a police officer. Okay. And why did this person get shot by the police officer? Because they just had a shooting spree at a concert. Okay. And shot a whole bunch of people. What do? Now you have to care for this person that you know just injured, possibly killed a whole bunch of people. What do you do?
You provide care like you're supposed to.
Right. You provide care like we're supposed to. However, you can see where emotions can run high in that situation, right? Because you know that this person just committed this crime and is now in need of medical services. And our job, just like Victor said, our job is to care. It doesn't matter who that person is. You can look at it this way, like I look at it this way. I'm going to give you the best care that I can so that you survive, right? So that you can go to trial and pay for whatever sins you just committed, right? Um, but think about, the way society is, all right? A lot has happened in society, right? With shootings. I've been around a while. 9/11 was a big one, with a lot of victims, right? There's always the potential for issues. But this is why I say understanding what your personal beliefs are. Um, we're nurses, right? We're going to be nurses and everybody has their own reasons for why they want to become a nurse, right? But the number one reason would be that you want to help people. And sometimes that puts us in a position where we may not always be comfortable. So, with that being said, what do you think is I'm going to just stay on this slide for a second. What if it is something that you don't feel like you could properly care for that patient? What do you think you should do?
Well, if the patient's already there and you're obligated to give medical care, give the medical care and then take up your grievances later after care's been done.
Okay, okay. Kashara, what would you do?
I was saying, before you take the assignment, you have the right to decline.
Okay, so see if somebody else can take that client for you, right? That is a potential option. And that is something that you could potentially do. Like if you felt like you really couldn't provide the care to that client, you could ask, another nurse to see if they could take the assignment. Just know that's not always a guarantee. But in and if if everybody else is like, no, we're not doing it either, right? Then that's ultimately your responsibility. But you do have, I mean, in some cases you may have that option. All right. So, individual autonomy and rights. So, individual autonomy means self-rule, okay? So, we all have our own ability to think and based on the thoughts that we have to make decisions freely. And with our clients, for the most part, it could be the decision whether or not to seek healthcare, right? The freedom to choose. Individual rights is the ability to assert one's rights, okay? And so we think about our patients and their ability to assert their rights. It is restricted in some cases, right? Of course, we know that their rights cannot restrict the rights of others. So In this example, the client's right to refuse treatments can be at odds with our duty to always act in a way that will benefit the client, right? Do good and prevent harm. Um, and so, if somebody comes in and let's say they're diagnosed with a cancer and they need, chemotherapy and radiation, and they've decided that they don't want chemo, they don't want radiation, they want to live their life the way they've been living their life, and what happens, happens, right? That goes against what we believe as healthcare providers, right? We want to make sure that we're providing care for them. Um, but individual rights are a central theme in healthcare. They have the right to consent to care. They have the right to choose between alternative treatments. They have the right to consent or refuse. And of course, women's rights over their own bodies. And this seems to be also another big debate. Um, and so um, you know, think about informed consent, and that's always a big one. When person's going to have any kind of invasive procedure, they need to know the good, the bad, the ugly about the treatment that's being offered, the good, the bad, the ugly about the alternative treatments that are there. And they have the right to make a decision based on what they believe is best for them. Um, so, it's always a big thing, but our ethical responsibility, advocacy. So, education, advocacy are always going to be at the forefront of nursing, right? And so, this is something that all nurses are responsible for. Any person that walks in the door, whether it's an emergency room, a clinic, or wherever it is in a vulnerable state. Even somebody that is coming in and is excited, I'm having my first baby. We're all excited. They are all in a vulnerable state, okay, because of for one, it's healthcare, all right, and we know in healthcare, there's always something that could potentially go wrong. So our job is to make sure that we're advocating for our clients. Knowledge is power. Can't tell you that enough. No, making sure that your clients or your patients are informed about their plan of care. And so a lot of times it's done every shift. And so, information, whether it's talking about their disease process, it's talking to them, talking them through the steps of a procedure. Any information that you provide to your clients is going to give them power. And so, even down to, who the members of the healthcare team are. Um, I have this. I don't know how to explain him. Doesn't have dementia, but was a little bit confused. He was at the VA hospital and he was transferred to rehab for physical therapy and occupational therapy. He had just resigned, he got to the facility late. And so, getting him settled, and one of the CNAs came up to me and said, um, that he was very upset that people just kept walking into his room and nobody was knocking on the door. And I said, well, that's just basic respect, right? You should always knock on your patient's doors, your client's doors before going in. So I said, okay, well, you know, make sure, I told the CNAs, make sure we're knocking when we go in the room. So anyway, long story short, I go to introduce myself. Okay. I knock on the door. I knocked as loud as I could to make sure that he heard that I knocked on the door. Um, and I really, in his state of mind, I'm still trying to figure it out, like where he thought he was, but he was like, where am I? And so I told him where he was. He said, why am I here? And I said, you're here for therapy, for physical therapy and occupational therapy. I said, to get stronger. And so, like, having this conversation, and he's like, well, all these people keep walking into my room and nobody's knocking. And I said, well, I apologize for this, right? We'll make sure that they knock on your door and everything like that. And he's like, okay. He said, well, I put my walker behind the door so that I can hear anybody if they come in. And I said, okay. He says, and I didn't get a key to my room. And I was really confused. I said, a key to your room? He goes, how come I don't have a key to my room? And I said, well, I kind of was like, I didn't know how to answer that question. I said, sir, think of this like a hospital, okay? I was like, we're not going to give you a key to your room, well, what about my stuff? Like he was all, and he was confused. It was late, as this was after 10 o'clock at night. So it's dark, right? Everything is, and at night things kind of seem more intensified than they do in the morning. So, um, it's just trying to give him as much information. I introduced myself. I brought the CNAs in. I told them, gave him as much of a schedule as I could, like what to expect the next day, to try to alleviate some confusion, get him to be a little bit more comfortable. But I will tell you that that walker stayed behind the door the whole night. Every time we went to go in the room, we had to like kind of push the door so that the walker would move out of the way for us to go in. Um, and then advocacy too is accepting the decisions that they make, okay? Um, and this could be, you don't have to agree with the decision. You don't have to support the decision. Advocacy is just, well, you have to support the decision. That's not what the word I wanted to use. You don't have to agree with the decision. So it could be that patient that has decided that they are not going to get cancer treatment, or the COPD patient that's not going to quit smoking. Okay. So we don't support the behaviors. Okay. We just still provide the care. We have to, kind of go along with their decision. And again, it's just about making sure education and knowledge, that we can give them. What does the word accountability mean to you?
I'm responsible for my errors.
Okay. Well, not just your errors, just everything you do, right? Hopefully we don't make errors, but we will. But yeah, you're responsible for your actions, right? So you're answerable to yourself, as well as your clients' families, your organization that you work at, your instructors, right? It's everybody. And so again, our accountability, you're held accountable for all of the nursing actions that you perform or that you are assigned to perform. And so when we think of nursing and accountability, okay, that's what we call the nursing standards of practice. Okay. So I'm sure you've heard standard of practice or standard of care numerous times throughout your programs, but basically that's what a prudent nurse with your education and experience would do in a similar situation. Colleague reporting. Now, I really hope that this is something that you never have to deal with in your nursing careers. Okay. When we look at colleague reporting, this is your peers, your supervisors, or any other team members, and reporting them for behaviors that are potentially harmful to clients. And I don't know what the word is, with all of the social media out there, people just tend to kind of go towards the social media aspect of it. Um, Whether your coworker comes in and it smells like they've been drinking or they've been using drugs, or you see someone that has diverted medications, somebody that is sleeping on duty, if they are not monitoring their clients appropriately, any verbal, any physical abuse, you are required to report that 100%. Okay. I would never confront anybody, but you have the right to report them. Um, So it's not just about, oh, having a body there. It is about what could happen to your patients. If your coworker is stealing narcotics, that means that your clients, those patients are not getting their pain medication. If they're sleeping on the job, what happens to your patients if, what happens to their patients if somebody codes or if somebody falls, if somebody needs something, they're not being properly monitored. So, and of course, we know abuse. Absolutely need to report abuse. And like I said, I hope this never happens to you. Um, it is unfortunate that there are increasing numbers of nurses that are losing their license for drug diversion. Um, and there's a variety of reasons that this happens, but as a future nurse, know that your license um, is a matter of public record. So any actions that are taken on your license, anybody can see. So, like if you go to your state board of nursing, and every state board of nursing is set up different, but you can look to see why, nursing or why nurses have gone before the board of nursing, why licenses have been revoked, suspended, or any of those reasons. But it is increasing that you're seeing more and more nurses are losing their license for drug diversion. And then we have our last one is system-based issues. So identifying system-based issues is essential to providing safe, high quality of care. So if a new piece of equipment, and I'm going to say this one is super important. If there's a new piece of equipment that is being implemented and you have not received training on it, do not use it. Do not use it. Make sure that you have received the appropriate training on how to use that piece of equipment. Um, and make sure that you know how to use it appropriately before you go to use it. If you have not received training, don't use it and report it. Report to administration. Like, hey, I can't use this piece of equipment. I've not been trained on it. And offer a solution. Maybe the educators can come in a little bit early, right, in the morning to get that overnight shift or stay a little bit late in the evenings to catch that overnight shift. I've been a nurse for a long time. We actually had a patient, well, not too long ago, probably about 6 months ago. Yes, it's been. He was at a facility and the CNA dropped him out of a Hoyer lift onto the floor, broke his shoulder and his hip in the process, plus a head injury. Um, we had another one who slid off a shower bed and sustained injuries. But the Hoyer lift thing, that's pretty common, unfortunately. And it's usually because the equipment is not being used appropriately. So again, if you don't know how to do or use something, don't do it. Always make sure that you are understand the policy, the procedure, and how to use that equipment. I remember this is, something I don't know if anybody knows, you guys know what kangaroo pumps are, for the tube feedings. They have one, which is the tube feeding, and then they have the flush. It's all in one. Have you guys seen those? No? Some have, some have. Okay, let me see if I can pull a picture up. So when I first started in nursing, okay, um, we had the tube feeding pumps that just delivered the tube feeding, right? You just hook it up and delivers the tube feeding, and then the nurses had to go in and do flushes, right? And so whatever the doctor ordered, however, and how much fluid they're supposed to get, whatever, but what was one of the biggest issues with our poor tube feeders is that they were constantly dehydrated. Why? Because they're getting a steady amount of fluid, but they weren't getting their flushes like they were supposed to. So they stayed dehydrated. And for those of you that don't, I'm gonna stop sharing and I'm gonna share my other screen. This is a kangaroo pump. And so where I was going with this was when these first came out and they transitioned to them, I was working night shift. Okay. I had no idea how to set this up, like whatsoever. Okay. So what it is you can do it one of two ways. So they come like this. You can have the two bag method, all right, where you put formula in one and water in the other. Or I don't know if they have the picture here, or they have another system where it's the bag of fluid and then another connector that you can connect to a tube feeding bottle. And then you attach it to the pump like this, and then you program the pump. And so it's going to deliver, let's say, 65 mLs of formula, per hour. And then maybe every, 2 hours, it'll do however many mLs of water. But this was a big issue for me because when they first came out, I had no idea how to use it. And here I had a patient, the tube feeding ran out, and I'm like, oh, I don't know, I have no idea what to do right now. And this was, I didn't have a Google to go and look to see how to do it. So it was a struggle. Fortunately for me, there was another nurse in the building that was able to come over and show me how to do it and help me figure it out so that, patient wasn't going to not get fed overnight. But these are things that happen, especially if you're a night shift nurse. So again, always be really careful. All right, let me go back to this. All right, so these are the big ones. All right, so ethical principles. These are the American Nurses Association. According to the American Nurses Association Code of Ethics, these are the ethical principles. The first one is non-maleficence or do no harm. Beneficence means to do good. Autonomy is the freedom to choose. It also is the role of privacy. Also is going to fall under autonomy. Fidelity means to be true, and justice is being fair to all. All right. So when we think of non-maleficence or do no harm, what are some things that come to mind with you when you think of do no harm?
Make sure you get the needle stick on the first time.
Get that blood drawn the first time, trying to get that IV in that first time. Okay. That could actually fall under that, yeah.
Providing care for the client, even when the ethical principles conflict with yours, like you were saying earlier.
Okay. Making sure you're providing care. Absolutely. It could be following the rights of medication administration, right? How many are there? 9 now, right? I think we're up to 9. The 3 checks. They could be, um, checking the temperature of the shower water before you put them in the shower. And then the little things that we teach you guys, bed in lowest position, right? Call bell within reach. Um, personal items within reach. Side rails up if you're in a hospital. Of course, we don't use side rails in long-term care. Um, what else? And then only providing the necessary procedures, right? We're not going and doing anything unnecessary. So like Victor was saying, right? Um, you know, if you try and you don't get it after the third time, right, we go get somebody else, right? We don't just keep trying just because. We're going to try to just get that, try to get that extra stick in. um it's also protecting those who can't protect themselves. Okay, so think of clients that have cognitive disabilities, whether it's dementia or and some other cognitive disability, right? They're a vulnerable population. Your unconscious patients, those are also vulnerable. Your weak, debilitated. Anybody, actually, I shouldn't say, I shouldn't even specify anybody that comes into our care is in a vulnerable state. And so we need to make sure that we are protecting them. When we think of beneficence or do good, okay, and I know well, this kind of sounds very similar, right, to do no harm, but um, this is something when we make a mistake, owning up to that mistake. You make a medication error, usually, I mean, the first responsibility is going to be your patient. Doesn't matter if it's a vitamin C, all right? If you give somebody a medication that they were not supposed to have, the wrong dose, whatever it is, your first responsibility is to your patient to make sure that you do an assessment and that they are okay. Um, it's making sure that, before you leave, that you are doing a turnover, that you're giving a full report to the oncoming nurse. One of the weirdest things, I'm not going to lie, one of the weirdest things about Texas is you don't have to give a shift turnover, like a verbal shift turnover. I know, Vanessa, I saw your head come up. I said, what? As long as there is a written report, I do not have to give a verbal report. It just blows my mind. I'm like, what? Not comfortable with that at all. But that's, part of being, that's part of beneficence is again, it's doing good, making sure that we're putting the good of the clients before our own. Autonomy, we talked about, this is the freedom to choose. Okay. And so this is thinking through the facts, deciding on what to do, acting based on that decision, and then understanding or undertaking a decision voluntary without pressure, whether it's direct or subtle. Okay, so it's that person that has that stage 4 cancer that has decided that they're not going to try, they don't want chemo, they don't want radiation, they don't want surgery, they just want to live out their life. Okay, that is the freedom of choice that our patients have. Um, and so I know it's not always the best, but they have the right to make the decisions about their treatment. They have the right to refuse treatment. All right. We look at privacy, and the role of autonomy and privacy, or the role of privacy and autonomy, sorry. Privacy is both an ethical and a legal issue. Um, and um, and so these are, when we think about privacy, and this isn't like it's not like HIPAA, okay? It's different. It's um, the reason why when you're at clinical, that your instructor will always go in first and say hi, be like, hi, my name is Jennifer, I'm a nursing instructor. I have some nursing students here today, and we wanted to know if it would be okay if, I had assigned a nursing student to you. It's just they have the right, or um, like if the patient's going for a procedure, hey, can I send a nursing student to go watch, that kind of thing. Um, it's just, it's a basic right to privacy. Because we know, unfortunately, that, not all patients are willing to have students take care of them, right? But again, privacy is that right to choose care, and it also gives them the right to decide who is going to care for them. Fidelity means to be true, okay? And so, oh, this is, being true to your clients. So if you are sitting at the nurses station and the UAPs or other nurses are talking bad about a patient or a client, right? You don't encourage that behavior. You tell them to stop. It is making sure that you're not talking about your clients in the elevator, in the cafeteria, at home, right? When you go home, you can't be like, oh, Mr. Jones said this and Mrs. Smith did this. And the next thing you know, there was an argument and a fist fight. And it's right. It's being true to your patients, um, and making sure that you are following through with that. Justice is fair treatment to all. Okay, so you need to deliver fair and equal treatment to all clients and recognize and avoid any personal biases that you may have. Okay, so you have two patients that come in. All right, let's say I'm going to use this example. All right, so you have a priest and a heroin addict. Okay, they both come into the emergency room in a hypertensive crisis. Okay. Should they both get the same level of care? Absolutely, right? They should receive the same level of care. Okay. So that's justice, right? Now, I will say that it just means that you're treating everybody the same. All right. And so your job is to provide that highest level of care possible. In long-term care, I'm going to tell you justice sometimes looks a little bit different, okay? Um, does anybody work in long-term care? Has anybody been in a, okay, so, you have Mrs. Jones and Mrs. Smith in the room together, okay? And whatever you do for Mrs. Jones, you better do for Mrs. Smith, right? It doesn't matter. It does not matter, okay? You file a nail on Mrs. Jones's finger, you better go over to Mrs. Smith and file that nail too, right? So sometimes it looks a little bit different. And it's just the environment that you're in, right? We just want to make sure that we're, avoiding any biases. Now, you might like Mrs. Jones a little bit better than you like Mrs. Smith, okay? But overall, right, you still need to provide that same level of care. Um, Now we have this thing. Um, and so it's called beneficent paternalism. And beneficent paternalism is a disrespectful attitude towards the client and what they have to contribute to their care and their recovery. It's an I know what's best for you attitude, okay? And it discounts the client's knowledge. So, you know, think about this because we do this with our kids. If you have kids, eat your dinner because I said so. Make your bed because I said so, right? That and not, we don't always do that, but I'm just using that as an example, right? We tell them what to do, right? They're our kids. All right. So having this type of attitude, now I will tell you sometimes it's hard not to, all right, but we're not supposed to have that type of attitude with our clients. Now I will tell you sometimes with dementia clients, it's kind of like dealing with little kids, okay? And sometimes you're like, oh, I just want to tell you to do this. Um, but again, it's a very disrespectful attitude. The only time where beneficent paternalism or paternalism is actually used would be in an emergency situation. Okay, so it's justified only in extreme circumstances, and it's most often a medical decision. So, and usually we see it with kids where the parents have declined or um, they've refused treatment for a child, and it's life-saving. And so the provider or the organization will petition the court to get a court order in order to perform that treatment. So let's say, and I'm going to use Jehovah Witnesses because this is a perfect example of where this would fit in. So we all know Jehovah Witnesses don't accept blood products, right? It's against their religion. So let's say we have a child who is a Jehovah Witness, let's say had a trauma and needs to have a blood transfusion, and it's absolutely life threatening. They have to have this blood transfusion in order to survive. The parents are going to say no, right? It's against their religion. The court or the provider can petition the court to get a judge to write a court order for that child to have that blood transfusion. Okay. Um, it isn't something that we take lightly in doing, okay? And, so, it's not like, oh, we'll just go to the court and do this. No, it's only in emergency situation, in a life-threatening situation where this will work or where this will happen. All right. So, the State Nurse Practice Act. Has anybody looked at your State Nurse Practice Act? I think I asked this last week. Has anybody? All right. So, your State Nurse Practice Act, whatever state that you are in, your Nurse Practice Act is law. Okay. So, you can Google Nurse Practice Act. You can look at your Board of Nursing website, whichever one is easier for you, and you can look at your Nurse Practice Act. The State Nurse Practice Act defines your nursing practice. It is the standards for nurses in your state. Okay. You must know your Nurse Practice Act. That is never going to be a defense that you don't know it was in your Nurse Practice Act. Okay. So any legal proceedings that may come against your license saying you didn't know is never going to be it's not going to look good for you. So again, it is super important. What I really like, about now, I don't, you know what, I'm going to tell you what, I haven't looked at all the states, um, but Texas, okay? For me, you have to have your continuing education units in order to renew your license, right? And so I do my continuing education through a website. I do it through, I think it's Nursing Central or whatever. And I don't know if Nursing Central sets this up or if it's the individual states that send the requirements in. However, what I'm going to say is one thing that I like about it is, um, the one of the or like one of the I guess one of the CEUs that they do is all about the Nurse Practice Act, which I think is awesome. It goes and it outlines the Nurse Practice Act for you, what an RN is responsible for, what they can do, as and then of course they call them vocational nurses here in Texas, so what the vocational nurse can do. So it's really kind of cool. I really like that. It really helped me, because there's another thing down here. It's called jurisprudence, and in order to transfer my license, I had to take this exam. Um, and I wish I had known about this other thing before. I would have read before I took because that test was hard, not gonna lie. But again, you need to know your Nurse Practice Act. That State Nurse Practice Act defines your nursing practice. Now, what's really nice about it is, especially since, I'm sure everybody has heard of the compact state, or compact licensure, whatever term you want to look at, there are similarities within that Nurse Practice Act across state, uh, across state lines. So from one state to the other. So let's say, I think a lot of you guys I got a couple or a couple Florida and mostly Ohio, but let's just use Ohio for example, right? You live in Ohio. I don't know, maybe you live closer to the Pennsylvania border, okay? And you decide that there's a hospital that you want to work in Pennsylvania, okay? And you have your compact license. Well, that's fine. Pennsylvania is compact state. You can go work in Pennsylvania. However, it is your responsibility to know what the Nurse Practice Act says in Pennsylvania as far as what you can and cannot do. Same thing if you live in Florida and you want to go work in Georgia or Alabama, okay? Perfectly fine, but you need to know what the Nurse Practice Act is in Georgia or Alabama, before you go do that, right? Or, better yet, you want to be a travel nurse and you want to go to Alaska, okay? All right, you have to know what the Nurse Practice Act says in Alaska. Most of it's very similar, okay, but things are changing, and the role of the LVN or LPN is expanding. All right. And so things that you guys can do as an LPN now, I couldn't have done as an LPN 30 years ago, right? So it's, it is something that you need to be really aware of. And that, again, it establishes the state guidelines for what you can and cannot do. Now, so that's like your umbrella. Okay. So you have your Nurse Practice Act as your umbrella. Then you go into your organization. Okay. Start working in, Hospital A. All right. Hospital A has to follow what that Nurse Practice Act. It can't go beyond that. So we know that LPNs cannot push IV medications, right? You can do IV meds. You can't push IV meds. There's a difference. Okay. The hospital can't say, oh, it's okay. You can push IV meds here. No, 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 no. You cannot. Okay. They can't go beyond that umbrella. Now, what they can do is restrict it or leave it. They can do is restrict it. So you can do IV meds, but let's say Hospital A says, we don't want LPNs working with IV meds. Okay. So that's the difference. They can't go beyond, but they can restrict a little bit. Oops. Um, so some of the other stuff that's in your Nurse Practice Act, okay? And there's a lot of stuff that you're going to find when go onto your Board of Nursing website. If you've not explored the Board of Nursing website, okay? There's lots of stuff on there. Some Board of Nursing websites are really easy to follow along and find things, others a little bit more difficult. So, the Nurse Practice Act, again, commonly include the general provisions. That's going to outline the functions of the Board of Nursing. It'll outline the general procedures or fees, the licensure process, like what do you have to do in order to apply for a license? What the elements of unprofessional conduct are. Information related to reasons for a suspended or revoked license, the impaired professional program, the responsibilities. So they'll outline the general functions of the licensed nurse. So LPN, LVN versus an RN. It will give a definition of nursing. So there is a specific definition for practical nursing versus professional nursing. Again, it'll outline the standards of professional conduct. Now, some states have one Nurse Practice Act that kind of just defines all of these things. Some states may have two Nurse Practice Acts, one for LPN, LVN, one for RN. Just depends on the state. It'll also the organization approval administration of nursing programs. So I don't know if you knew this, but the State Board of Nursing is responsible for approving nursing programs, as well as determining your education, your continuing education. This is something to pay attention to, and I unfortunately have seen nurses get their license suspended for this reason. Sorry, one of my dogs just got sick. Um, Continuing education credits is determined by the Board of Nursing. Okay, so make sure you know how many hours of CEs that you have to have in order to renew your license and keep up with that. Okay, so most state boards of nursing say 2 years to renew your license. Okay, that doesn't mean 30 days before your license is due, you do 2 years worth of continuing education. Okay, they're going to look at the dates. You have to have them every year. But the Nurse Practice Act will tell you that as well. And that's going to bring us to the functions of the Board of Nursing. We're going to take a break. Let's be back at 3:05. All right. Has anybody heard from Jasmine?
Professor Martinez, I wanted to ask, did you get my email on
I did.
Canvas?
I'm gonna
Okay.
reply back to you. Yep. Thank
Okay.
you.
You're welcome.
All right. So we look at common functions of the board. Okay. So again, like I said, sometimes they have one specific nurse practice act for both sets, the practical nurses as well as registered nurses. Sometimes they'll have two distinct nurse practice acts. It really just doesn't, it just depends. They also have variety of committees and councils within the state boards of nursing. So some of the common functions of the nursing board. So licensing and certifying. So specialty certification. So like if you as an LPN decide to go get your long-term care certification, your IV certification, a lot of times those may be through another association like NAPNES, or the NFLPN. It just really depends. It sets the fees. Okay, how much does it cost for you to get your license initially? How much is it going to cost for you to renew your license? It establishes the standards for educational programs. So some of you may know the boards of nursing. They're the ones that outline what has to be presented within the nursing programs. It said, it tells us how many clinical hours that you are supposed to have. So a lot of specific guidelines. It also approves the schools of nursing. Okay, so if I decide I want to open a nursing school, okay, I can't just open a nursing school and start graduating nursing. I have to graduating nurses. I have to go through the board of nursing. They are the ones that approve all schools of nursing. They determine the duration and the renewal of licenses. Okay, so is it every 1 year? Is it every 2 years? Every 3 years? Whatever it is. Most are two. Some boards are different. Again, some boards require continuing education credits for the renewal of licenses. So be very aware of that. For example, when I lived in Virginia for the longest time, they didn't require continuing education credits. I don't remember when they started, but I forget when they started it, but then they changed and they said, yeah, nurses have to have continuing education credits now. They maintain inactive status lists. They carry out disciplinary actions for violators. They develop programs for impaired nurses. They also suspend and revoke licenses and deal with the appeal process. So, impaired nurses. So, I said one of your responsibilities is to report to your supervisors, if one of your coworkers is not caring for their clients or is impaired at work. State boards of nursing have impaired nursing programs where if there is a drug addiction or alcohol issue, there is a program that they can go through to avoid losing their license. Now, their licenses will be suspended, but if they go through the program, they have a better chance of getting their license back. They also will outline what is considered unprofessional conduct. Okay. The goal of the boards of nursing is to protect the public. Okay. It is not to protect nurses, it is to protect the public. So they outline what is considered unprofessional conduct. So negligence. Okay, negligence is the nurse does not do what a reasonable, prudent nurse would do in a similar situation. Okay, so it involves serious risks to the health, safety, or physical or mental health of a client. Violations of the Nurse Practice Act. Okay, some states' Nurse Practice Act lists specific violations like becoming personally involved with a client. I don't know what I saw. I think it was a vlog where a nurse, I don't remember, I want to say it was Virginia, but I could be wrong in the state, who lost her license because she became involved with an inmate at the jail that she was working at. Um, Incompetence. So this examples include failure to meet generally accepted standards of nursing practice, negligence, and a nurse's mental disability that would interfere with client safety. Unethical conduct, breach of nurse-client confidentiality, refusal to provide nursing care for someone because of race, creed, color, national origin, disease, or sexual orientation, violation of the ethical code for nurses, and failure to maintain nursing competence. And then alcohol or other drug abuse. Alcohol and other drug abuse by a nurse, whether it's diversion of drugs like controlled substances for personal use, is a threat to client safety. Some nurses steal and sell diverted substances and equipment, such as syringes and IV tubing, falsify client records, and deprive clients of their medications. Okay, so these are some examples. Now, this isn't an all-inclusive list, okay, but these are some of what the boards of nursing would list as unprofessional conduct. So the disciplinary responsibility for the board, right? So there's things that they can do that are within their power. They can do a fine or a civil penalty. They can refer to an alternative to discipline program for practice monitoring and recovery support. So like I said, if they have, if there's that impaired nurse program within the State Board of Nursing, they can refer to that. They can do a public reprimand or censure for minor violations without putting a restriction on the license. They can do requirements for monitoring, remediation, education, or other provision tailored to the particular situation. For example, okay, one of the facilities that I worked at before I left Virginia, um, there was a nurse that was working there, um, prior to me working there, who got reported to the Board of Nursing. Now, why he did this, I do not know. Okay. Apparently he called in sick, and most places have a thing where you call in sick for, you can call in sick for up to 3 days. And then after that, you need to have a doctor's note, right? I mean, that's just how most places work. So they asked him for a doctor's note. And so he provided them with a doctor's note. However, apparently it was forged. And so it was a forged doctor's note. So they reported him to the Board of Nursing. How they found out it was forged, I don't know, but I just thought that was interesting. So he, instead of having his license suspended, revoked, or anything like that, they had him do continuing education. I don't know what it was on, ethics or something along those lines. And once he submitted that, they reinstated his license and he was good to go. But yeah, some of the things I've seen, we had one who, this was somebody that I worked with, unknowing, I did not know. I didn't work with her very often. So like the shift that I worked, I was a team lead on a skilled care unit. So I worked 8:30 to 5. She was the 3 to 11 supervisor. So we didn't have a whole lot of interaction. Um, Apparently, and this was back when I was LPN, she was an RN. So anytime there is narc destruction, and the process has since changed as well. So a lot of narcotics, especially on rehab unit, because we get a lot of post-op patients who are still in pain. Narcotics are supposed to have two nurses that witness the destruction, right? And so she took it upon herself to destroy unused narcotics. Instead of destroying the unused narcotics, she was pocketing the unused narcotics. Some of them she was using for herself, others she was selling out on the street, and got caught. Trying to think of what else. Those are the two big ones that came to mind that are just, I mean, we hear about nurses stealing narcotics all the time. The problem with that is, especially in your post-op patients, you are falsifying their medical records because you're pulling the narcotics, but you're not giving it to the patient, but you're documenting that you're giving to the patient. So it doesn't look like you're stealing the medicine. Um, they can limit or restrict one or more aspects of practice. So they can do probation with certain restrictions, limiting the role, setting activities, hours worked, things like that. So when I first moved to Texas, I worked with an LPN, um, who I don't know how, I don't remember the whole story. I think he told me, but I'm not sure. He was actually restricted. He couldn't work long-term care for a period of 2 years, for whatever reason. So they can restrict that. They can restrict whether you can work full-time or part-time. Um, they can say, okay, you can work, but you can't work around narcotics. Okay, somebody else would have to do all your narcotics for you. They can recommend separation from practice for a period of time so they can suspend your license, whether it's a specific period of time or until you meet specific requirements, or they can revoke your license, or in some cases, the nurse can voluntarily surrender their license. They can do remediation, so educational content or exercises. There may be other state-specific things that may be done. So I was reading one where it was a new nurse who was working in long-term care, and was not passing her meds. Um, they like basically like some people would get their medications and others would not get their medications. And basically, long story short, I think it came down to during the investigation, they were saying that, or she was saying that she just didn't have enough time and that she didn't get the orientation that she was supposed to get and, outlined some of the other issues. And so she just had to do some continuing education, um, and her license was reinstated. So they don't want to suspend your license. They don't want to revoke your license. We have a nursing shortage. Okay. Some states are worse than others. Um, they, for the most part, are willing to work with the nurses, but you have to remember that public safety is always going to be their biggest concern. So this is kind of how it works. Okay. So a nurse is reported for stealing a client's narcotics to the State Board of Nursing. Okay, so then the State Board of Nursing is going to receive the complaint. They are going to determine that, that chemical has affected the nurse's judgment, rendering them unsafe to practice. They're going to confirm the stolen narcotics are a violation of the Nurse Practice Act and the law, and then the board is going to review the complaint. And then, if they determine that it is a violation of the Nurse Practice Act, they are going to then do investigation. So they are going to conduct interviews, question witness, gather evidence. Now, when I tell you they gather evidence and they do interviews, I was surprised. I've never been in front of the board of nursing myself, okay? But some of these things that I've seen, they'll go back to previous employers and they will interview previous employers as well to see if there was any issues. Like they do, and when they investigate, they investigate. And then once they do their interviews and they have all their evidence, then that goes to the board proceedings. And at the board proceedings, that is where the nurse gets to respond to the allegations against them. And so they, the board action follows the board proceedings, and that's where they'll determine the disciplinary action. And so they can do an immediate action. So they can do an immediate suspension to protect the public pending the complete investigation. They can do disciplinary action or they can do remediation. And once all is said and done, when we talk about reporting, let me get some name. Yeah. Nurses, NURSYS, that is a national database for verifying licenses, discipline and action privileges for nurses. So if you go on nurses and once you get your license, I suggest that you register on nurses. And it will help, it just kind of helps you, what's the word I'm looking for? If there's like any updates or any changes or whatever, then you can I'm trying to pull it up, but for some reason it wasn't. There it is. Um, it'll notify you. So, and it helps to keep your information current as well. So, if I'm just gonna show you what this looks like real quick. Actually, I'm gonna search by. There's a lot of Jennifer Martinez's here in Texas. So but I'll show you what it looks like. I'll just pull up my license. Oops. All right. So, oh, it pulled up the wrong state. Dupe. I was like, what? My license isn't there. All right. So I'll show you. Um, So this is the nurse's website. I know my license number. So I put my license number in, my license type, I put my state, and I'll hit search. I was gonna say it should come up. So it'll come up with like a brief summary. So you can see my practical nursing license from Virginia is here, my registered nursing license. When I moved to Texas, I told you, there's a process. So, of course, the background check and all that stuff, I also had to do that jurisprudence. So, they issue you a temporary license number while you're in that process. And then once you're complete, you get your regular license number. So this is the information that you'll see. If I hit view report, okay, then it'll give even more information. So like my practical nursing license is expired, my RN license is expired in Virginia, but you will see that my Texas license is fine. It is unencumbered. So I, if I had something on my license that I did something bad at some point, then this would not say unencumbered. Okay, there would be something else there. And I have a multi-state license, so I do have a compact license so that I can practice in other states if I want to. And this is what I was saying, like you can sign up for nurses. I don't know which one it is. I do have an account, but you just get updates and alerts, and every once in a while it'll ask you to go in there and verify your information. Now, everybody has as an employer, I would use nurses to look up anybody that I was employing so that I could get their full report. Now, if I hit download report, it's just going to give me the same information. It's not going to tell me anything. I was just like, I was just trying to see. So, like you can see, there were some issues here. So it'll tell you like if there's any specific board of nursing stuff. But yes, anybody, your nursing license is public record, so anybody can look. Um, but if there was any kind of disciplinary action on my nursing license, then you would be able to see that. If I went, I will show you. I'm going to show you Virginia because Virginia is, to me, it's an easy website to look up. And, sometimes people are nosy. So, um, let's see. So, like, this is the Virginia Board of Nursing website. Okay. So, like I said, this one for me is pretty easy to use. So, like, under public resources, you can see there's a complaint, there's a license lookup, and there's case decisions. So, if you wanted to look up a nursing license in Virginia, you would hit license lookup. If you want to look to see why people get their license suspended or revoked, you go to case decisions. So then you can choose your board. So these are all the different boards that fall under the Department of Health Professionals. So if I hit nursing and hit enter, you can see why people, so you can see anybody that's gone in front of the Board of Nursing. And so right now I can tell you a lot of the surrendered license are due to that Project Nightingale in Florida. You guys hear about that? The school that graduated a whole bunch of people that didn't go to nursing school. So you'll see a lot of surrendered licenses. There was a lot in Virginia, New York. I can't remember. There was a couple other states as well. Let's see. I'm trying to see if I can. This one was that's Med Aid. Well, here's a suspension. Let's see. So then you can click on that and then click on it and it will show you. I'm just gonna try this box is in my way. So it'll tell you somewhere. I scroll down right here. It'll tell everything that they did. So this one, she was impaired and she went to work. So it'll outline every single thing that she did while employed, as to why she got her license. I'm trying to think of them. Usually, I don't know why. Let's see. Um, I don't know anybody. I'm just trying to like see if there's revocation. Oh, here's a suspension. Let's see. Not the greatest. Um, all right. So sometimes you can't read them. Mental illness or substance abuse. That's why she was suspended. So again, it is all public record. You can go to any of the Board of Nursing websites. Texas's looks a little bit different, although I will tell you, Texas sends out a bulletin. I think it's like quarterly, and lists all the nurses in Texas like on their bulletin and just mails it to you. And I'm like, okay. So yeah, so just be mindful that anything that you do in whether you're at work or outside of work, I've seen a couple where they've gotten in trouble for shoplifting, for DUIs, um, assault and battery, and that has affected their nursing license. Now, it just depends if the board of nursing finds out about it. Sometimes they do, sometimes they don't. But just know that anything you do outside of work is just as, important as what you do work. So that's what nurses looks like. I've never looked at the National Provider Data Bank, the National Practitioner Data Bank, but that's another one. Federal law does require that adverse actions taken against a healthcare professional's license be reported to the National Practitioner Data Bank. And then the State Board of Nursing online verification provides public information about nurses who have current licenses. So what I showed you with nurses is a little bit different. The state boards of nursing, for the most part, it's your nursing license, your expiration date, and if there's any like disciplinary action against your license. Some boards of nursing give a little bit more information, which I think Florida, this bothers me as a nurse because of the current state of the world right now. But Florida actually puts your physical address on your license. So if I were to like pull up a Florida, I'm trying to think, I don't know if I was gonna say I only know one nurse in Florida, but I don't know if she would still be on here. Um, so it actually, if I go to, let's see, licensing, home, verify license, let's see. So, oh, this one doesn't. Because it's expired. But the I was talking to a student about this a couple terms ago, but yeah, this one doesn't because my mom was the only one that had a Florida license, but she passed away and but her license is expired, so it's not going to have any information. But um, they have their home addresses on their like on the verification, which I don't know with the current state of the world and things like I don't know if I agree with that. But for the most part, like I said, it's just going to be um, your nurse's license number, the registration, the expiration date, and if there's any action against your license. Just remember that your stuff, again, it is a matter of public record. Anybody has the ability to go to the Board of Nursing website and look up your license. So things to think about when we look at this. Nursing licensure. So initially you'll get, right, a temporary permit. So, um, like I was telling you when I even when I transitioned from Virginia to Texas, right? I've been a nurse for many years already and still had a temporary permit, right? Because I was still in that, transitioning phase. Um, you guys um will once you graduate, right, you have to apply for the Board of Nursing to get your nursing license. And you'll have to do your background check. Background check's a lot different now. It's a national background check versus just a state background check, especially if you want to get that compact license. Compact license, I mean, there's lots of benefits for this, okay? And so once you have a license, I told you, I had to take a jurisprudence exam. That's fine. I didn't have to take any other courses. I didn't have to do any other, whatever. Um, so you can work in other states with your license, but you have to be registered in your home of record. So, for example, um, when I first moved down here, okay, so I moved to Texas because I was here and I knew I was going to stay here. You have 6 months to transition, right, your license. So, but let's say I want to take a travel contract and go to Virginia, okay? So I can work in Virginia under my Texas license, okay, as long as I know what the Nurse Practice Act is. Um, so the benefits of the compact license, the license compact is great, right? You can work across state lines. You just have to make sure that when you apply for a license that you apply for the multi-state license and not just a state-only license. Other states, like I don't know if it's true anymore, but like New York, you used to have to take like a child abuse like mini module. So it just depends on what state that you are going to. But Once you're licensed, the process of licensing in another state is very simple. Um, so just know that that does make it a little bit easier. The biggest issue that you may see, especially working within other states, is supervision of your UAPs. Okay, so just like with nurses, okay, they have a nurse practice act, or they have, I don't know if it's really not a nurse practice like act, but they have, a set of things that they can and cannot do. And that's going to vary by state as well. All right. So you have to be mindful of that. And especially with NCLEX, the NCLEX is a national exam. Okay. So it's not specific to Ohio, Virginia, Florida, Texas. It is all of the states all together. So just because a UAP can't do something in your state doesn't mean that they can't do it in another state. Okay, that's the one thing that you have to, kind of understand when it comes to NCLEX. So it is interesting that I wrote one down and I don't remember where I wrote it down, but I was like, no way, I had no idea. I'll have to find it. I will find it because I thought that was interesting. I was like, I didn't know that they could do that. Um, was it suctioning? I think it was suctioning. Not the sterile suctioning, but they could do the oral suctioning. And never, I mean, I've never asked a CNA to do suctioning before. Sometimes depending on where I'm working, CNAs can't do vital signs, right? So I have to be like, are you guys allowed to do vital signs here or not? Um, but I thought that was interesting that some CNAs are, can do suctioning depending on where they are. So just keep in mind that when we comes to NCLEX and even HESI, when we look at delegation and supervision, it's not specific to your state. It is a national exam. So you have to kind of understand that there's going to be some things that, even though they can't do it in your state, they can do it in others. Nursing standard of care, talked about this a little bit. So, and I'm sure you've heard standard of care before. But the nursing standard of care that's your guideline. That's your guideline for good nursing care. All right. So, it has legal implications. The standard is based on what ordinary prudent nurse with similar education and nursing experience would do in a similar circumstance. Okay. And so when we look at this, the resources for the nursing standard of care, your Nurse Practice Act. Okay, I can't say that enough. Your Nurse Practice Act, you need to read your Nurse Practice Act. That identifies the minimum level of competency necessary for a person to function as a nurse in your state. Your NCLEX, okay, the National Council Licensing Exam, it tests for minimum competence. And I say minimum competence. Your nursing programs, doesn't matter where you go. You go to Fortis, you go to a 4-year universal, wherever it is, we all teach basically the same thing, okay? We teach and we give you the minimum competence, okay? And I know it sounds a lot because there's a lot of school and there's a lot of things that you learn in nursing school, okay? It is minimum competence. What we teach you is just the tip of the iceberg. When you get out into practice, you are going to learn so much more. Your nursing programs, okay, based on guidelines from the Board of Nursing, okay, our nursing program, your nursing programs, Fortis nursing program is guaranteeing you a minimum knowledge base and the clinical practice necessary to promote safe nursing care. Minimum, okay, not minimal. Okay, there's a difference. The minimum, okay? There is no way that we can teach you everything I'd probably still be in school 30 years later, okay? But your curriculum, your textbooks, your instructors, these are all resources for you about standard of care. Organizational policies and procedures. Okay, so wherever you're working, wherever you decide to go work, um, a hospital, a clinic, the long-term care, the agency that employs you is also going to provide a standard of nursing care that must be followed. So that's the organization's policies and procedures. If there's ever an issue, the lawyer is going to use the agency's policy and procedure manual as a guide of your expected behavior. Trying to think of what else. Of course, the law is also, there as well. Um, when we look at law, we have criminal and we have civil law. Okay, so criminal law is government versus individual. All right, so felony or misdemeanor charges, homicide, larceny, embezzlement, those would be, you got the state attorney, they're coming after you, right? You're going in front of the judge, okay? Civil is individual versus individual. So you get into a car accident and that person decides to sue you. That's a civil case, right? That's individual to individual. It's the same thing with nursing or healthcare. Um, it is individual versus individual. So it's an infringement on somebody's rights. And usually the result is going to be some sort of monetary compensation, right? They want to be reimbursed basically for pain and suffering, for lost wages, for, whatever. And so that's usually what that ends up being. These are things like intentional torts or unintentional torts. So, an intentional tort is something, um, it's intended to cause harm to the client. So, you, I don't know, so we had somebody who, trying to think of something, that would fall under this. Um, you gave Oh my gosh. You smacked a patient, okay? That was intended to cause harm, okay? Or you threatened to smack the patient, all right? That is an intent to cause harm. That would be an intentional tort. An unintentional tort, you didn't mean to harm the client. So maybe you gave the wrong medication. All right. You didn't mean to, but you didn't follow the nine rights. You didn't do your three checks. You gave the person the wrong medication, which caused injury, and that would be an unintentional tort. Yeah, that's the best. So again, intentional torts, assault and battery. People get assault and battery mixed up all the time. Okay. Assault is the threat. I am going to beat you up. Okay. Battery is the beating, right? That is the actual physical touch. People got these. It makes me angry when I like see certain things or hear certain things and they're like, that's assault. That's assault. No, it's not. That's battery. Like I just, but okay. Assault is me threatening you. Battery is me beating you. All right. False imprisonment and use of restraints. Okay, so false imprisonment is keeping someone detained against their will. All right, so this can include the use of restraints. It could it could be keeping someone secluded in their room. Um, it also could be the chemical restraints like medication. Um, we don't use restraints in long-term cares, so don't know a whole lot about them anymore. Um, it is different in the hospitals. Restraints are allowed, but there are very specific guidelines for using restraints, to be very careful. False imprisonment also is, somebody wants to leave AMA and you're preventing them from leaving the building. Okay. So be very careful with that. Defamation is damaging reputation through either false communication or communication without their permission. Okay, and with defamation, we have libel and we have slander. Libel is written. Okay, so I write a letter to the newspaper and I say all these horrible things about somebody. Okay, that is written communication that's libel, and they publish it in their nuppaper or whatever. Slander is verbalizing. So here I can, I'm gonna talk bad about my dog. She's really bad gas, and she's the one that just got sick in the hallway. Okay. Okay, so that's slander. Actually, it's true. She's lazy too. Okay, but that's slander. All right. It's basically it's gossip, right? You're talking about it, somebody to somebody else. And then, of course, we have physical or emotional abuse. Okay, so physical abuse, we know really easy to see physical abuse, especially in a patient. There's going to be bruises that are in various stages of healing. There may even be fractures in various stages in healing. We can usually see physical abuse. Emotional abuse, on the other hand, is very hard to identify, right? Because it doesn't leave those physical harms or those physical, like, I don't know, what's the word I'm looking for? What's the word I'm looking for? My dog's not helping. The physical marks, okay? And so emotional abuse is very difficult. If you suspect abuse, okay, every organization has some sort of a process for you to follow. Make sure you follow that process. Usually you're gonna, report it to your supervisor, your manager, or somebody along those lines. And so but you need to know what your organization policy is as well as what the state guidelines are for reporting abuse. And it doesn't matter if it's in somebody's home, if it's out in public, if you witness abuse, if you suspect abuse, you are 100% required to report. As long as you make a report in good faith, okay? You can't report your next door neighbor because you don't like them just to try to get them in trouble, okay? You have to it has to be in good faith. Um, in some states, like I was saying, child abuse training may be mandated for licensure or renewal. And I think it was New York. I'm pretty sure it was New York that made that it required some sort of a child abuse course. Again, those unintentional torts are going to be negligence, malpractice, and contracts. So we will get into these. So negligence, all right, is failure to use such care as reasonably prudent and careful person would use under similar circumstances. So we got two nurses, similar experiences, similar expertise, okay, and we're going to basically use that against, right? This is what we determine is that standard of care. A common type of negligence is going to be that personal injury. Okay, so be mindful of that. Malpractice is professional negligence. All right, that's just the legal name for negligence. It's plain and simple. So we just use in the nursing world or the healthcare world, we use the term malpractice. And with that, we have what are called acts of commission and acts of omission. Okay. So the difference is an act of commission is you did something. Okay. So you gave the wrong medication. Okay. An act of omission, you didn't give the medication at all. Okay, one you did wrong, the other one you just didn't do it. And those are usually where nurses come into trouble. So again, some common sources of malpractice, medication errors, working while impaired, failure to follow standard of care, lack of observation and timely reporting about the client. I can't say this enough. Know your clients. Failure to use a medical device accurately. Like I told you before, if you don't know how to do and you've not been trained on doing it, don't use it. Failure to communicate. failure to properly supervise a client, negligent delegation and supervision, failure to act as an advocate, and failure to get informed consent. These are some common, that means that they happen very often. So being aware, just be very careful. You guys work too hard during nursing school, okay? Work too hard, get through nursing school, pass your NCLEX to go out and lose your license. Be very mindful of what you are doing and don't cut corners. Malpractice insurance. I was just looking at something about this today. So, more nurses now are being named in lawsuits. Okay, so nurses, you are liable for your own actions. Okay, so there's a variety of things. Even nursing students should have their own malpractice insurance. Um, there's a common misconception that nursing students work under their instructor's license. That is absolutely not true. Okay, your instructor's license is her license and only she can work under it. Okay, she is responsible to supervise you, but your actions are your actions. And so why you should have your own malpractice insurance. So, for one, okay, the jury's award could exceed the limits of your agency's coverage. Yes, now a lot of your agencies that you work for, they have some sort of a malpractice insurance that's going to cover you. But let's say um, you have to go to court and the jury awards, I'm just throwing out a number because I don't know, $20,000, but the agency's coverage is only $10,000. Where do you think that other $10,000 is going to come from? It's not coming from the agency. It's going to come from your pocket.
Is this one they can countersue you?
Yes. Yep. Your employee agency could pay out an award and then countersue you. Okay, we just paid it out for your negligence. Now you got to pay us back. You acted outside the scope of employment and the art agency argues it's not liable. Your employer's policy covers you only on the job, or this is another one you have to think about. An agency might carry a policy that covers you only while you're employed by that institution. So there's a statute of limitations, right? So something could have happened. You didn't even know it was an issue. You go on to work at another job, and then all of a sudden, here comes this case. Okay, that agency, because you don't work for them anymore, may not cover you. And your current agency isn't going to cover you because the incident didn't happen where they were at. So there is that gap. I was, and I haven't heard anything about the student. Okay, so I'm gonna hold off. I don't know, I don't know what happened. So anyway, one HCA hospital is really big. I know in Florida, they're kind of up and down the East Coast. Um, and they're down here in Texas as well. Like, I don't know how big HCA is. I know it's really big. They own Galen School of Nursing. Anyway, so HCA Hospital is suing Rasmussen University, which is another big nursing school, okay? Because a nursing student from Rasmussen, um, apparently, and all I know is that he was on a floor he wasn't assigned to. The nursing instructor wasn't present, but he decided to help an elderly client transfer. In the process of the transfer, the client fell, hit her head, and died from I think it was a subdural hematoma. Okay. Now, the, of course, the family sued HCA, and now HCA is suing the nursing school Rasmussen for failure to properly supervise the students. I guess they had an indemnity clause that said that, anything that happened that, Rasmussen would have to pay. And so HCA paid, whatever the penalty was to the family. And now, Rasmussen was supposed to give them basically reimburse them and hasn't done so. So now they're suing them. I do know that the nurse, the student that was involved, did graduate and is an RN, but I don't know if they're, if they're gonna go, like, I don't know if there's anything gonna happen to him and his license. Um, but like I said, it is always better to CYA, as they say, because you don't want to be stuck in a position where, something happens, because some of these can, be pretty expensive. Let's go ahead and well, give me one second. So we'll talk about these a little bit more. So in order to prove negligence, we're going to leave this on the note and we'll talk about them after break. There's four elements that are needed: duty, breach of duty, damages, and proximate cause. And so we'll break down each one of those when we come back from break. So let's be back at 4:10. All right, so let's go ahead and finish this up. All right, so like I said, the four elements that that are needed to prove negligence are duty, breach of duty, damages, and proximate cause. So when we look at duty, duty refers to your responsibility to provide care in an acceptable way. Okay, so this, the nurse or you as the nurse, you have the duty based on your education as well as the policy and procedures where you work. Okay. Breach of duty means that you did not adhere to the nursing standard of care. Okay, so whether it was an act of omission, so what was expected of you wasn't done, or was not done correctly, which is an act of commission. Okay, an expert nurse witness is going to be the one that establishes the standard of care. Damages mean that the client must be able to show that the nurse's negligent act injured him or her in some way. Okay, the client has the responsibility. They have to prove the damage. Okay, and then the proximate cause means that there's a reasonable cause and effect relationship between either the act of omission or the act of commission of the nursing act caused the harm to the client. So basically, did the nurse's negligent care or act cause the injury in question? So, for example, patient has hypertension, okay? And nurse was really busy, okay? Nurse had duty to care for the client. And let's say nurse got really busy, forgot, did not give the client their hypertension medication. The client had a stroke. Okay. So the client has to be able to prove that there was a cause and effect, that the nurse not giving him his antihypertensive medication is what caused the stroke and the resulting damage. Okay. Or it could be, the client has diabetes, all right, and the nurse clipped his toenails and caused a cut on the tip of his toe, which then proceeded to go to, become gangrenous and necrotic, and he loses his big toe. Okay, the client has the responsibility to prove that there was that cause and effect relationship. Okay. So, what happens, all right, in that situation? All right. So, the client thinks that the nurse violated their rights or caused this whatever to happen. So they're going to go get an attorney, right? We're a very litigious society. Okay? So they're going to go seek the advice of an attorney. Before anything goes any further than that, okay, the attorney is going to have a nurse expert review the chart, okay? So they're going to get all the charts, and that attorney is going to have this nurse expert review everything to determine if the nurse violated the standard of care. If there was a violation in the standard of care, that is when there will be a lawsuit filed. A lot of cases don't ever get to this point because when that nurse expert reviews it, if there's no standard of care deviation, right, it won't go any further. So if there is a violation, okay, then the client is going to file a complaint that documents whatever the violation of the rights were, and then that is going to be served to the defendant, which is in this case the nurse, okay? And then the nurse or the defendant is going to respond, and that's where the pretrial or the discovery period begins. So they're going to get statements from the nurses. are from the nurse, the witnesses, the nurse expert, the plaintiff, other caregivers. They're going to review all the policy and procedures of the organization. So that's your depositions, the discovery period. And then we go during the trial, then that information is then presented either to the judge or the judge and the jury, depending. And then the verdict is rendered. Okay. The plaintiff, okay, the client is the one that has the burden of proof. They have to be able to prove that cause and effect relationship. And then within a malpractice suit, the award is usually monetary, right? It's to make them whole again, right? Again, it's usually a monetary settlement. And then there is always the appeal process. So if the plaintiff wins, the nurse can appeal the decision. If, the plaintiff loses, then he can appeal the decision. So there is always that option for appeal. But remember, what the first thing that's going to happen is that nurse expert is going to review that chart to look for any deviations in that standard of care. All right, so here we go. So the nurse caring for a client miscalculated the dose of medication administered it to the client, who was successfully resuscitated. Okay, so miscalculated the dose, okay, but the client was successfully resuscitated anyway. Is that an intentional or unintentional tort?
Unintentional.
Unintentional, right? I don't think they intended, right, to miscalculate. Is that negligence?
Yes.
Okay. So the nurse committed an unintentional tort, right? And harm was not intended, but did not maintain the standard of nursing care and did not do what a prudent nurse would do. So yes, it's still negligent. Um, so again, and I know, oh no, dosage calculations, nobody likes it. But I will promise you it is so important that you pay attention, and you do your dosage calculations. Always double check, always triple check, have somebody else look at it. So we get into privacy and confidentiality, information that must be revealed. And so we teach you about HIPAA and we tell you not to tell anybody anything that they're not supposed to do. But in all situations, or in certain situations, we must reveal information, okay, which is not going to be a violation of HIPAA or their privacy. Okay, so again, some laws require that certain client information be reported without the client's consent. And again, the purpose here is to protect the public. Okay, it's not like we want to just go out and share a whole bunch of information. So, communicable diseases. Okay, communicable diseases are reported to the local health department or sometimes the Centers for Disease Control and Prevention. This includes AIDS. Okay. The list is available in your local health department. Okay, so maybe different across the states, but you can always look at your health department, your state health department to see which diseases are reportable. Vaccine related adverse reactions. These are reported to the Department of Health and Human Services. Let's see, criminal acts. All states, all states mandate reporting of rape cases. Some mandate reporting of injuries by gunshot or sharp instruments as well. Some states require reporting of blood alcohol levels beyond the legal limit. So you have to know what your state mandates are. Equipment related equipment related injuries as well. And so when the use of a medical device results in injury or death, it is reported to your supervisor and the healthcare provider. If emergency first aid is called for, then you're going to follow those procedures. When there is a clear and present danger, HIPAA laws, for instance, mandate reporting of client mistreatment or professional misconduct. So again, you're going to go directly to your supervisor or follow your policy and procedures. Child abuse or neglect of either a child or the elderly. So you're going to report the incident immediately to your supervisor, your DON, whoever it is, and then they'll follow up with the reporting procedures. It varies on where you are. Um, so again, abuse or neglect of the child or the elderly is who we primarily, report. Now, adults are a tricky situation. Okay. Um, let's say myself. Okay. Let's say I had an abusive husband or is an abusive relationship. I go to the emergency room because I had sustained injuries as related to the abuse. Um, and is that mandatory? Are you required to report that as an adult? And you required to report my abuse? Ooh, I know I put you in. This is a tricky one. No. Okay.
You offer
Why?
brochures, right?
Huh?
You offer the brochures.
Yeah. We offer resources, but why? Why is it different? Why is it different? It's like a double standard, right? But why is it different?
They may not want help or not ready to receive help.
They may not be ready to receive help. That's a really good point. The other one is too, if I'm with my abuser and my abuser found out that I told the nurse, yeah, I'm being abused, and they call the cops, what does that put me at risk for? Escalation, right? What if their kids at home? Like there's too many different, scenarios that can play out. So child or elderly abuse or neglect, those that are cognitively impaired as well would fall under our vulnerable population. Do have to be careful with the average adult, whether it's male or female, because we have males that are abused as well. Patients' rights, patient care partnership. So any facility that you go into, you see it in the hospitals, in doctors' offices. There is a client's rights, patient rights. Um, and so they've been changed and amended. But some of the clients' rights, they have the right to high quality care, a clean and safe environment, involvement in their care. They should be involved in their care, protection of their privacy, help when leaving the hospital, and help with their billing claims. Okay, these are outlined in the patient's Bill of Rights or client's rights, however you want to call it. Then we have HIPAA. All right, so Health Insurance Portability and Accountability Act took, I was like in 2003, somewhere along there. It was, yeah, it was passed earlier, but it didn't go into effect until 2003. But anyway, the biggest thing with HIPAA was, the portability, of course, but one of the biggest things was the privacy part of it, right? Um, and so it's maintaining patients' privacy. So when coordinating client care, you need to adhere to the minimum necessary rules to protect the client's privacy. But, and I was around when this first came out, and there was a lot of hiccups in the process. Okay. Let's say I'm discharging a patient. All right. patients leaving the hospital and they need to have some durable medical equipment delivered to their home. Okay. So it's not a violation of HIPAA if I give them their client's name, their address, as well as their payer information. Okay. So I'm going to call, ABC DME company, and I'm going to say, Mrs. Jones needs to have a hospital bed, delivered to her house at, 123 Broadway Street. Okay. And her insurance is United Healthcare. Here's their, here's the, whatever the policy number. You're allowed to do that. All right. Any other information, then they can get that from the client later on, but you are allowed to give out that information to a vendor. HIPAA also requires that all covered entities designate a privacy officer. So when you go to the doctor's office, usually the first time you go that year, everybody signs a update to their HIPAA privacy. I don't ever read it. I've read enough of them. Worked in a doctor's office for a while, so I know basically what they say, but you have access to it. Within that, HIPAA does require that all organizations have a designated privacy officer. So, what does that mean? If they keep a copy of their HIPAA form, they should have it. But if I'm in the hospital and I don't know, something happens and I feel like my privacy was violated, then the nurse should be able to provide me with either the privacy practice information or the name of the privacy officer. And I would contact that privacy officer and file a complaint. Okay. So every organization has a privacy officer that is going to be responsible for handling those HIPAA complaints. Other parts of this chapter, client competency. So this is a really big one too. You may not come into contact with all of these different things, but legally, okay, we look at competency. It's 18 years or older, a pregnant or married woman, a self-supporting minor, which we used to call them legally emancipated, or they are competent in the eyes of the law. So everybody is competent until you are determined by the court to be incompetent. All right. And I can't just say, oh, you're incompetent. And no, the court is the one that is going to determine competency. Clinical competency is, ability to understand the problem, what your options are, and to make decisions based on sound reason. Okay, kind of like that informed consent, right? With different types of consent. So we have general consent, we have implied, and we have informed, and we have authorized. Okay, general consent. You go to the doctor, you go to the emergency room, right? What's one of the first things that they have you do? Sign a consent form. Basically, that's just you're authorizing them or allowing them to treat you. All right. And so this can, and imply or general or implied consent can be revoked, whether orally or written at any point. Okay. AMA, right? You go to the emergency room, you're like, I'm not getting care I need, I'm leaving AMA, right? That is your absolute right. Informed consent. This is the one that we need to get for any any invasive procedures, whether it's therapeutic or invasive. All right. So during informed consent, this is right. They're going to know what the diagnosis is or what the suspected diagnosis is, because maybe we need to do the procedure in order to, right, confirm a diagnosis. The purpose, the description of the treatment. Okay. Some surgeons may just, send the client home with a link to a YouTube video. right? And that's the way a lot of people are doing things now. When I had my cataract surgery, the surgeon just had me sit there and watch a YouTube video of the cataract surgery. So, that kind of addresses multiple types of learning, right? Um, so, and then once they, watch the video, they'll have the opportunity to ask questions and then sign their consent. The expected outcomes, right? The benefits. Also, what are the potential complications or side effects of the procedure? And as well as any alternative treatments that are offered, right? Also, who is going to be performing the procedure? What are their qualifications? If I don't get the treatment, what's my prognosis? And then, like I said, answers to any questions that they have, and that they have the right to revoke their consent at any point. Authorized consent, parents give authorized consent for their children. Okay. So, for the most part, right, a minor is usually someone under the age of 18. So, parents give authorized consent for their kids. Why is it not informed consent? Because the child is not giving consent for themselves. It's authorized consent. So I already talked about this. So again, to make that informed decision, right? Diagnosis, the purpose, the expected outcomes, benefits, good, bad, and ugly, as well as the good, bad, and ugly of any alternative treatments, who is going to perform the procedure, their qualifications, the prognosis if they don't have it done, any answers to questions, and that they have the right to remove or revoke written permission at any time. And then we get into end of life issues. So with end of life, we have a couple of different things, okay? First one is a living will. All right. A living will is not used to specify someone to make healthcare decisions for you. These are your decisions, okay? So you should make this while you're young and you're able-minded, okay? But should you become incapacitated or unable to make decisions for yourself, your living will outline everything that you want or do not want done. Okay. Um, tube feedings. Do you want CPR? Do you want IV? Do you want pain meds? Do you want to donate your tissues? Do you want, I don't know, whatever it is that you want, okay, in the event that you can't make decisions for yourself. The durable power of attorney, on the other hand, is kind of like a living will, except you are assigning a healthcare proxy to make decisions for you. The durable power of attorney is also valid in all 50 states. So this is something that you can carry with you in your back pocket if you wanted to. But it identifies a healthcare proxy to make decisions for you in the event that you are not able to make them for yourself. Okay, so it's your living will being enacted through another person. All right, gotta make sure that you choose somebody that you trust explicitly in order to carry out what you want to have done. DNR order as a do not resuscitate order. It is an advanced directive. It's based on the Patient Self-Determination Act. So, what does this mean? You go to your doctor and you say, I want to be a DNR. I don't want to have any resuscitative efforts should something happen to me. Then the doctor can write that order that says you will be a DNR. Okay. And so again, it is based off of that Patient Self-Determination Act that, hey, I don't want any life-saving anything. The doctor can then write that order for you to be a DNR. The ones that get it tattooed on their chest, that is not a legal order. Okay. If you come across somebody and you're getting ready to do CPR and it says DNR on their chest, unless they have a signed DNR from their healthcare provider, you're going to do CPR. Has anybody heard of the Good Samaritan Act before? So the Good Samaritan Act is you can look it up, it's in your state. But the Good Samaritan Act is there to protect anybody that renders emergency care in good faith at the scene of an accident. It should be immune from civil liability for their actions. Again, each state laws vary. So you would have to look it up for your state. It is there to encourage healthcare providers to stop at the scene of the accident and render care in good faith. As long as you don't act outside of your scope of practice, you usually are covered under the Good Samaritan Act. All right, and then the last little part here, we'll talk about euthanasia. Okay. So yeah. All right. So euthanasia, okay, and physicians assisted suicide, they're not the same thing. Okay. Physician assisted suicide refers to a healthcare provider providing the means for death. Okay. So there are a couple states where physician assisted suicide is legal. Okay. And again, the physician just provides the means. So usually it's prescription drugs. They'll, write the prescription, and then the client or the person is the one that ultimately administers their own medications, right? So on the other hand of that, we have euthanasia. Euthanasia generally means that the healthcare provider would act directly to end a client's life. Okay. There's lots of big controversy about this. Dr. Kevorkian was the forerunner of this. If you've heard of Dr. Kevorkian, he's a little bit older. Some of y'all are a little bit younger, but um, so yes. With that, we have active and passive euthanasia. Okay, so active euthanasia are actions that speed the process of dying. They actively end the person's life and they initiate the dying process. It is morally wrong and legally not allowed. Okay, it is also forbidden by professional organizations. Your passive euthanasia avoids prolonging a person's life. It allows to continue a process that causes death. It is morally permissible and legally allowed, and it is approved by professional organizations. Okay. So think about, let's see. So when we look at it, all right. So first of all, the American Nurses Association released a position statement, okay, that states that nurses are not allowed to participate not verbatim, but we are not to participate in active euthanasia. Okay, it is against the code of ethics for nurses. All right, so it recognizes that assisted suicide and euthanasia continue to be debated. All right. So, okay. But again, it is strictly prohibited that nurses have any process in that. When we look at this passive process, and I'm going to stop sharing for a minute. We look at the passive process. Hospice is part of nursing care that deals with end of life. Okay. And when we look at passive euthanasia, we're not doing anything to preserve life. Okay. We're not doing surgeries. We're not doing chemo. We're not doing radiation. We're not, treating anything at this point. We are just allowing that person to continue to go through the dying process. Okay. Now, when we have someone who is, in that dying process, we may give them pain medication, which may hasten their death or cause them to die a little bit faster. But it also relieves their suffering, right? And so that is the difference. We are not causing their death. They're actively dying. We're relieving their suffering. So that is the difference, okay? Versus us, giving them, um, some other medication that's going to cause them to die. Sometimes it feels like there is a little bit of a gray area there, I guess. But like I said, there are, some states out there that have the physician's assisted suicide, that it is legal. I know Oregon was probably the forerunner of that. And I think Washington as well. And there's others that are out there too. I think New Jersey is one where it is. But that again, that's physicians assisted. The physician will assist with that process. Let's see. Other than that, I think that covers everything for today. Any questions for me?
Hi, Professor Martinez. I heard that you said the Florida group is supposed to be paired with the other group, but I'm a part of the Florida group.
Correct.
I'm supposed to be with Kashar, but I'm not with Kashar. I'm not in Kashar's group. And me and Kashar goes to the same school.
And so there's only two Florida students, so I partnered them up with people from Columbus.
Okay.
So it's not just, yeah, otherwise there would only be two people in that group. And so I split them up as best as I could.
Okay.